All right. Good morning, everybody. Thank you for the introduction. We're gonna jump into it and introduce our panelists here. But just to give you a little bit of background. Oh, thank you. I appreciate it. So we're going to start everything and introduce our panelists, but just to give a little bit more background. Okay. So while surgery and chemotherapy and radiation are crucial in treating head and neck cancer, it often comes with challenging and long-lasting side effects that affect both the physical, functional, and overall emotional well-being of our survivors. This symposium session is really designed to address the specific concerns of survivors and needs who are undergoing or have undergone treatments and are navigating and managing these painful side effects. Our medical experts, which are our panel here, as well as our tongue cancer survivor, will explore the common side effects experienced by head and neck cancer patients, and will also hopefully gain valuable insights and strategies and interventions that will help you to better manage, improve quality of life, increase mobility and function, and help to support long-term well-being. After the presentations, there will be a Q&A session that will be addressing questions from the symposium, both in person as well as remotely. So feel free to introduce yourself on the chat and submit questions through the Q&A in the Zoom. So we're going to introduce each panel member to start. Susan Smith, she's a survivor panelist, and then the medical panelist from MD Anderson Cancer Center at Cooper. We have Ian Lawrence, a speech pathologist, Jamie Wigton, a physical therapist, and Dr. Angela Capriotti, a palliative medicine physician. So thank you all. I just wanted to give a little background on Susan's cancer journey that started during the COVID-19 pandemic. At that time, she was grappling with a serious illness that was not related to the virus, but despite months of eating difficulties and significant weight loss, it took a year and 4 different doctors to diagnose her with stage 4 tongue cancer. Susan was diagnosed with stage 4A tongue cancer, meaning the cancer had spread to her lymph nodes. She underwent a 15-hour surgery that involved a removal of 40% of her tongue and 30 lymph nodes. The surgery was also included reconstructive procedures to rebuild her tongue and reconstruct her forearm. Following surgery, Susan had just 6 weeks before starting a rigorous treatment regimen of 30 radiation sessions and 6 rounds of chemotherapy.
Thank you. Hi, everybody. It's very strange to hear a summary of what you've been through for the past 4 years. I think when they asked me to speak today about survivorship and what that means and what that looks like and what I wish I had known, the things that come to mind are I wish I had really understood how difficult treatment would be, and that I really wish I had a better handle on how long the recovery would actually be. I remember I had a doctor say to me, oh, it will be a few months, which I really laugh about now at this point. As a tongue cancer survivor, there are daily impacts that I have to navigate as part of my life. And while I'm 4 years out from my treatment, those impacts don't really change day to day. They continue and they persist. You know, I want to be careful about sort of how much I speak about the negative, because there's also positive and there are ways to overcome a lot of those impacts. Starting with speech. After my treatment, I was extremely difficult to understand. My speech was very garbled. It was like having cotton cheek to cheek. And early on, and I know we have speech pathologists in the room and speech therapists in the room, but early on I saw a speech therapist who said to me that I would need to wrap my arms around this being my new voice and that I would have to accept it. And at that point, it was almost impossible to understand what I was saying. And I think it's important to know that you have other resources and other support you can go to if the answer you're getting is not the one you want to hear. It took me a lot of time focusing with a different speech therapist who handed me a stack of exercises, and I did those religiously. I sang in the car. I took a book and read out loud to learn how to get volume behind my voice. And all of those tips and tricks and focus allowed me to get my speech to where it is today. I will not say it was quick. Most of my improvement around my speech happened about 6, 8, even 10 months after I finished treatment. So I think that it's important to understand that sometimes your progress might take a little bit longer than maybe medical professionals or maybe other patients are experiencing, and that it's a matter of focusing and dedicating your time and your effort so that you can reach those kind of milestones and improvement. The second area is around pain. I had reconstruction in my mouth using a free flap from my arm and a skin graft from my leg, and a neck dissection, as was mentioned. So I think pain was widespread in my body. I certainly prescribed to all of the medications possible following treatment and during treatment, but afterwards, I realized that there was going to be a continued impact, mostly from radiation. So I do have things like fibrosis and scar tissue and stiffness. And for any of you with head and neck cancer, you'll understand that a lot of those impacts then affect how you are speaking and how you are swallowing food. So it's important to focus in on constantly kind of combating those impacts. I do see a physical therapist, but not just a physical therapist who looks at knees and backs. I see a physical therapist who specializes in head and neck oncology, who is also a lymphatic masseuse. And that's important because it means that they can holistically treat me and the impacts that I face every single day. I went religiously for therapy after treatment a couple times a week. I still go 4 years out a couple times a month because that fibrosis kind of constantly wants to take over. It's like a fight every single day to push back on the stiffness and the hardness that can start to form as a result of the radiation. Third area I will say is eating and oral care. I think there are other survivors who will speak more to this today, so I won't go too far because this could probably make up a full day of content. Eating is a challenge. I know I am very lucky to be able to eat the way I do now, but it didn't start that way. I found it very challenging to eat. Through treatment, I lost 52 pounds and was hospitalized for malnourishment a couple times. So when I say treatment wasn't easy, it wasn't. But I think after treatment, someone said to me, keep a food journal, and I found that so important because it allowed me to see what I was struggling to eat, what I wanted to try to eat, and how I could make progress moving forward. So I could go back 3 months, 6 months, 9 months and see, okay, now I can eat that cracker or that chip, but it took me, kind of a year almost to get to that point of being able to eat and push past the pain and the discomfort that I was feeling when I was eating. I will say for me in survivorship, food is about taking control. I'm someone who goes out a lot with friends and family and for work, for meals. I think it's so important as a survivor to take control of where you are eating and what you are eating. I highly recommend being the person that chooses the restaurant so you can look at the menu beforehand and you can decide if there's something there that will be easy for you to eat. Having that control, I think, as a survivor allows you to reduce your anxiety and make sure that you are feeling comfortable versus the people that are around you feeling comfortable. And then last, I'll talk about well-being, certainly not least. I think as a survivor, and what I've learned from talking to a lot of patients, is that when you're done treatment, there really isn't always a handoff to a mental health expert. For me, going through treatment was, okay, what am I doing every day? Where am I going? What's my appointment? It was very much a head down mentality for me of getting through it. So when I was done treatment, it was a little scary, to say the least. I didn't know who to turn to, who to talk to. I felt depressed. I see a lot of patients who are able to kind of turn the page, go to the next chapter, and move on very freely, and that just wasn't me. I very much suffered with the grief and the trauma of going through and the shock of having a cancer diagnosis like I did. So I think it's important to, if you are not handed a mental health expert to speak with, that you seek one out. And again, one who specializes in oncology patients, who understands what it's like for a typical patient. I also think it's so important to turn to support groups like the Head and Neck Cancer Alliance. I'm also very lucky to be part of a group called Young Tongues, which is comprised of nothing but tongue cancer patients across the globe. And those are people who understand exactly what's going on in my mouth, what's going on in my neck, and what are my challenges every single day as I move forward in survivorship. I think coming out of the treatment, I will never be the person who says that cancer is a gift. But what I will say is that cancer gives perspective. And for me, it's very much about balancing those daily struggles and challenges with happiness and leaning into the things that bring me joy. And it's kayaking, it's going to the beach, it's even grabbing a sled and sledding at the age of 50, which I don't recommend. It's scary. But I think, it's very much, to me, about leaning on the people who are around you and reaching out to people who are going through something similar so that you make sure you're able to spend your time the way that you want to and the way that brings you the most happiness. Thank you.
I'm going to stand. Sorry, Jamie. Can you hear me back there? Good. All right. Let me know. So thank you, Lara. Thank you, Susan. That was fantastic. And good morning to you all. My name is Ian. I'm a speech therapist. I work at Cooper University Hospital in the MD Anderson Cancer Center at Cooper. And I have the privilege to talk to you today about coping with long-term dysphagia after being treated for head and neck cancer. And right off the bat, that word dysphagia, just in case anybody doesn't know, that just means a swallow impairment. So if you have trouble swallowing, you're experiencing dysphagia. All right? So I'm going to talk to you about the nature of dysphagia. Okay, thank you. Keep it coming. I'll talk to you about the nature of dysphagia in the setting of head and neck cancer. Also, how we can evaluate swallow function and the therapy we can provide. And more so geared towards the long-term survivors who are coping with a chronic impairment. This is my hero right here. Go ahead. Okay. We'll talk about some tips that other long... There we go. Is that good? Yes. Okay. Excellent. Well, gotta protect the voice, right? I'm a speech therapist. Just talk about some things, some strategies people use to sort of to cope with that and adjust to life after head and neck cancer. And Susan talked about this a little bit. All right, so we begin with a quote from Hippocrates, the father of modern medicine himself. Let food be thy medicine, and let medicine be thy food. That's pretty good, right? I think it's actually a nice little summary of the underlying philosophy that goes into managing swallow function throughout the head and neck cancer process. It's important to stay active and to keep eating and drinking before, during, and after treatment. That's the best way to promote long-term swallow function. And it's a nice quote, and it's true, but it's also easier said than done, isn't it? As many of you know, it can be very, very difficult to eat and drink after you've had this treatment. It can be painful. In some situations, it can even be unsafe. So that is the challenge that we face with this type of impairment. All right, so how common is dysphagia after you've been treated for head and neck cancer? The short answer is it's very common, but it's been researched. You'll get different numbers depending on where you look. I think it's interesting to Google things now and then because I think most patients, when they're first diagnosed, they Google. So I Googled it. Google told me 50 to 60% will have dysphagia. Okay, so it's a pretty big number. The folks at MD Anderson in Houston, they've done a ton of great research over the years on patients like yourselves, and they did better than Googling. This guy's great. I'm gonna bring you home with me. No, it's good. So yeah, one study they did, they looked at Medicare claims over a 10-year period, and that they found that patients with head and neck cancer 45% of those patients had dysphagia, and they were 4 to 8 times more likely to have dysphagia compared to people without cancer. And they also saw that the risk for an impairment increased as the amount or complexity of the cancer treatment increased, which, so for example, patients who had radiation and chemotherapy were at higher risk compared to patients who had radiation alone. And that makes sense, right? The more treatment you get, the more susceptible you are to experiencing these treatment side effects that can affect swallow function. I've got a few of the classic symptoms displayed there that some of you might be experiencing. It's important to keep in mind that there's a wide range of potential severity with these deficits, but when the side effects are severe, they can lead to a significant impairment and potentially profoundly impact your health and your quality of life to the degree that you need to restrict what you're eating or modify the food that you're eating in order to make it easier for you to swallow. And there can be risk for malnutrition or pneumonia due to aspiration. This is when food goes down to the lungs instead of the stomach. And in some cases, people ultimately will rely on feeding tubes or tube feeds through feeding tubes, because eating and drinking is just not a viable means of obtaining the nutrition that they need to heal and to live their lives. So a speech therapist can evaluate swallowing in numerous different ways. A clinical swallow evaluation is essentially a consultation with a speech therapist where we'll ask you a lot of questions. We want to take a look inside your mouth, see how things are moving, and we'll watch you eat and drink a few things just to get a sense for what it looks like when you're swallowing and what bothers you about your swallow function. You know, what are your unique problems? It gives us a lot of great information, but oftentimes we also want to do a more thorough and objective assessment, and that's where all these acronyms come into play. So I've got a screenshot here of a modified barium swallow study or a video fluoroscopic swallow study. These long, cumbersome names for what's really a pretty simple test. We basically watch you eat in front of an X-ray camera. And using the camera, I can see inside your mouth and your throat to get a good, clear picture about how everything is moving around and to understand the nature of your problem. We also have the option of a FEES. So I'm sure many, if not all of you, have experienced that long, skinny camera that was inserted through the nose and into your throat. Ah, yeah, right, beautiful. I want to use this opportunity to say I've gotten a lot of feedback lately that the speech therapists at Cooper do a better job with the scope than the surgeons. I just want to put that on record. We can talk about that later. We can fight. So during a FEES, we insert the scope into the throat and we feed you while the scope is in place. And it just gives us, again, a clear picture about how your throat is working when you swallow. And that can help us tailor therapy, find specific therapy targets. So therapy can involve numerous different approaches or techniques, but generally speaking, a speech therapist will help you experiment with different foods in a safe setting, right? We'll provide some strategies to help you compensate for your impairment today, while also giving you some exercises designed to reduce the impairment over time. We need to educate you, of course. It's important that you understand the impairment that you have and what we're doing to try to fix it. And in many cases, we'll refer patients to other specialists who have different sets of skills so we can attack the problem from different angles. And you'll hear from other professionals later today, of course. All right, but head and neck cancer, it's a serious disease, requires serious treatment. And the reality is, many people who get treated for head and neck cancer will experience some degree of chronic dysphagia. And there's an impact on your physical health, but also there can be an emotional impact, psychological impact. Susan mentioned a lot of this already. Patients describe losing a source of pleasure in their lives. Eating used to be fun, used to be enjoyable, and now it's no fun. Now it's a task. It's something I need to do, just a box I need to check each day. Also, patients describe a sense of emotional loss. We all have a relationship with food, don't we? We can all think of foods that are sort of tied to our culture, or our identity. And when we say we love certain foods, we mean that. We really love them. I love chocolate chip cookies. I love them. It's a problem, right? And you're all thinking of your own examples right now. If that was taken away from you for any reason, that would trigger a real, genuine sense of loss in your life. This can be such a pervasive and persistent problem that it can lead to strained personal relationships, right? You've all been through this process together, you and your loved ones. and you're done your treatment, the cancer is gone, but you're still going through it. And sometimes even that really helpful and crucial encouragement, it can be seen as nagging or just evidence that maybe my loved one doesn't fully understand the problem I'm going through right now. And of course, social withdrawal. So much of our social lives is centered around eating and drinking. So if you're having trouble swallowing, maybe that cup of coffee with a friend is not such a good idea, and people tend to withdraw because of that. All right. But there is hope. All right. All is not lost. Other people have been through this before, right? This is the whole reason why this type of organization exists. People have faced these issues, and they've come up with their little strategies to help them cope with the ongoing problems they face. Susan spoke about this brilliantly. There's kind of a balance between pushing and trying to improve, but also accepting that your life is different now, and how do we move on from that? The best thing you can do right up top, connect with fellow survivors of head and neck cancer. So you're here, you're doing that. That is genuinely, in my opinion, the best thing you can do to help yourself move on from this experience is to meet other people who have had the experience. I tell patients, I know a lot about this, I've been doing it for a while. I've never had head and neck cancer. Hippocrates never had head and neck cancer, as far as I know. So talk to other people who've gone through the experience. They'll help you adapt, help you move on. Definitely continue to experiment. Many of my patients talk about how they established a routine or a set of habits to help them get through the treatment. But then when they're done their treatment, it's difficult to let go of those routines because they've come to rely on them so much. But when they do push themselves, they keep sort of taking calculated risks. They're often surprised at how much they can do over time. So keep working at it. But also don't work at it too much. Take days off, right? You've been through a lot. You have. So it's okay to take a day off from therapy or talk to your loved ones about, maybe picking one day each week where you're not going to encourage me about my swallow function. We're just going to leave it alone today. Right? You talked about a lot of things before you had cancer. Spend a day to talk about all that stuff again. Get back into it. And practice patience. And this is tough for all of us, of course, but practice patience. Don't just be patient. Really practice it. Work at it. Susan spoke about this. Having head and neck cancer and recovering from it, it's a long-term process and in many ways a lifelong process. So be kind to yourself, be patient with yourself, continue to communicate with others and seek help. And over time that you develop these adaptations to your new life, and hopefully that can help you accept your new normal. Things are not how they were before you had cancer. They're different now. But you can move on from that and adjust and deal with it just like you've dealt with everything else that's been thrown at you. And that's my presentation. So thank you all for listening.
Okay, can you guys hear me in the back? Okay. So my name is Jamie. I'm a physical therapist at MD Anderson Cooper. And chances are that most of you have had physical therapy, maybe for something in the past, like an ankle sprain or something like that. But just in case you are unfamiliar, I'm going to read you the official definition of a physical therapist from the American Physical Therapy Association. So physical therapists are licensed doctors who examine, diagnose, and treat movement dysfunction. They improve quality of life through prescribed exercise, hands-on care, and patient education. I cannot tell you time and time again from my family, my friends, physicians, even other physical therapists, they say to me, but I don't understand. What do you do with people with the cancer in their mouth? And I'm here to tell you that unfortunately there's a lot of things that we can do with the people with the cancer in their mouth. I've squeezed several impairments on here. There's about 15 that have been identified through research that our head and neck cancer survivors are suffering from. And I squeezed them on here on purpose to make the list look exhausting. Our patients, by the time they get to me, they are exhausted by dealing with many of these, if not more than one or two. So there's a lot for us to work on, and this isn't just physical therapy. This is a combination of speech therapy and occupational therapy as well. So I could talk about everything on the list, but we'd be here all day. So I'm just going to choose one that I get a lot of referrals to from our physicians and from Ian and our other speech therapist, Holly. and that is lymphedema. So lymphedema is an abnormal accumulation of protein-rich fluid within your soft tissues. Studies are a little varied in this population, but it seems that as many as 50 to 90% of our head and neck cancer patients have some sort of lymphedema. I'm going to give you a very brief anatomy lesson. If you look at the picture with the green on the left, the green demonstrate your lymph nodes. You have about 300 in your head and your neck region. And what happens, if you look at the picture on the right, the fluid flows from your face, usually about laterally and down. And it just has to get to your subclavian region, which is right here. So it's really not that far. And that's how the lymphatics drain all the fluid from your face. The reason why we have lymphedema in this population, it can vary. It's usually, though, caused by either surgery that will remove a lymph node or actually a decrease in lymphatic contractility function, and that's associated with radiation therapy. Finally, an actual tumor can be obstructing the lymphatics. If progressed and not treated, lymphedema can lead to chronic inflammation, fibrosclerotic and fatty dense tissue that can result in a permanent deformity. This will impact your swallowing, your phonation, or ability to speak, your neck range of motion, your body image, and lastly, your quality of life. It can involve both internal and external structures. This is an example of external lymphedema. It's sort of obvious, but it's visible swelling in the soft tissues in your head and your neck. These patients often identify themselves. They feel tightness and discomfort, and a lot of times they come in with that turkey waddle appearance. But more intriguing to me is actually internal lymphedema. There is very little information out there about internal lymphedema, and this would be swelling and actually the underlying mucosa and soft tissues of your upper aerodigestive tract. So that could be your pharynx, your larynx, your esophagus, your mouth, and even your facial sinuses. These are the patients that are coming to me with feelings of strangulation when they're lying flat, or that they feel like when they go to swallow, the hole in the back of their throat just isn't as big as it used to be. And also, if it's like a sinal lymphedema, they can have like a dull pain in their ears. So despite such a high percentage of these patients having lymphedema, it is definitely underdiagnosed, it's understudied, and it's definitely undertreated. This is mostly because internal lymphedema is not readily apparent to the external eye. You can't walk into your physician's clinic or identify on yourself, oh, you look fine, but how does everyone know that you're swollen on the inside? Other reasons that lymphedema is often underdiagnosed in head and neck cancer is because there's no control to compare it to. Unlike an arm, we can't say, oh, your arm looks more swollen than the other one. And also, there's no standard criterion for diagnosis for a head and neck lymphedema. So most of what we know in this population, we actually borrow from breast cancer research. The treatment is still the standard of care across the board that we would any other body part, and that's following what's called complete decongestive therapy. So this consists of manual lymphatic drainage, compression, exercise, and skincare. So manual lymphatic drainage is basically a skin stretch massage, and you follow the pathways of the lymphatics and move the fluid to known regional lymph nodes that aren't affected. This can easily be taught to patients, even family members, for your face, your neck, and even inside of your mouth. We typically have our patients wear some sort of a compression garment. This is myself and my lovely colleagues modeling some of the stuff that we have in our shelves at MD Anderson. We also use taping, other stuff like that as well. It's kind of nice because we usually have you wear the compression when you're laying down because that's when we don't have gravity to assist with drainage. So usually you only have to wear it overnight or in the privacy of your own home, and you do not have to go out in public looking like this, don't worry. We work a lot for exercise on postural strengthening and control as well as muscles that help you swallow. We want to have good posture. You want to stay open so that lymphatic fluid can flow from your face and get down to right above your collarbone where it needs to go. It's important to note that all of our patients are discharged with lifelong management. Theoretically, lymphedema is chronic, so these patients are taught to keep up with their manual lymphatic drainage and their compression really for the rest of their lives. I do want to add just two little tidbits, and this is what I tell everyone that comes into my office. Don't freak out if you are swollen right after surgery or radiation. That's normal. Your body's going through a normal inflammatory process. You do not have lymphedema. We usually only start to worry about it if it lingers a little over 6 weeks after treatment. And most important, research has found that the patients that do the best are those that come in for therapy within their first year of cancer diagnosis and treatment. So the earlier we can treat, the more successful you will be. So I just wanted to include two quick patient cases that we co-treated with speech therapy and physical therapy at MD Anderson Cooper. Both of these patients were identified by speech therapy on Fee's study. Don't worry, I'm not mean and I don't shove the camera up your nose. So they were identified, if you look on the left, that's before treatment. I'm gonna have Ian, can you turn your mic on?
Oh, can you hear me?
Oh, good.
Good, okay.
I'm gonna have Ian identify, but both of these patients were in severe pain, being managed with prescription pain medicines. They were unable to lay flat. They were both sleeping on either a couch or a recliner, and they were obviously seeing speech therapy because they were having trouble swallowing.
Yeah, so these images were taken from the Fee's procedure that I mentioned. So we're looking down into the throat at the structures of the voice box. And the one on the left, you can see everything's kind of puffed up and bulky. On the right, we're a little bit slimmed down, more defined. I think the clearest thing you can see is that on the left, you can see maybe half of the vocal cords, but on the right, you can see the majority of the vocal cords, just a sign that things have opened up a little bit better. Structures have more room to move.
And then here's one, sorry, Ian, this one's backwards because when we did the screenshot, you know, we're a little technology
That's my fault.
challenged.
Same idea. The one on the right, everything is puffed up. It's swollen. There's just not as much space for everything to move around. On the left, everything is a bit more well-defined. You can see those openings more clearly.
Okay, so after treatment, both of these patients were able to return to laying and then sleeping in a bed without waking up. Both of them were off prescription pain medicine, and both of them had improved swallow, according to our lovely speech therapist. So in conclusion, I just recommend that if you're experiencing any of the 15 impairments identified for our cancer survivors, that you seek a referral to a rehab specialist, because we just might be able to help you a little bit more.
Hi everyone, I'm Angela Capriotti. I'm one of the palliative medicine attending physicians at MD Anderson, Cooper, and Cooper University Hospital. Thank you for having me today. So really just our objectives is just to go through pain and discomfort that may be associated with head and neck cancer care. And just to kind of walk us through and keep us on track, really wanted to introduce what palliative medicine is and also review some just potential pain syndromes that your patients may experience. Okay. So to talk a little bit about palliative care is best introduced at the time of a serious diagnosis, including a new head and neck cancer. The easiest way to think about palliative medicine is that we're integrated before survivorship or before hospice. And it's always with the best recommended care treatment. So it's really important just to reassure patients that if you want to include us as part of their multidisciplinary cancer care, that it's nothing to be fearful of. We're here to walk with them through the whole process. Our responsibilities are pretty large range. We take care of all the symptoms that are associated with cancer that patients may face. That includes both cancer-related pain, treatment-related pain, and any non-pain symptoms. So some of the other challenges that our patients who are facing cancer care that they may experience may include nausea, vomiting, fatigue, low appetite, a sense of general well-being as they're kind of coping through a new serious illness. So we take all those into account as some of the symptom burdens that our patients may face as they're walking through cancer care. A large part of what we do is really integrating psychosocial support as part of our normal encounters, patient visit, patient care, and at times, depending on how things go with their cancer care course, we may assist in difficult medical decision-making and just some preparedness planning, which is the concept of being prepared for any outcome while hoping for the best together, which is hopefully survivorship and a cure. I always like to just bring some attention to just the differences between palliative medicine and hospice care, as they're often used interchangeably, but I think it's, again, the easiest way to think about us is really along with the best recommended therapy and before hospice and hopefully before survivorship. A lot of the elements are the same. As with any specialty, we treat physical symptoms and also non-physical ones. Our emphasis is really the symptoms that can impact a patient's function and their quality of life. We are also part of a multidisciplinary team approach, so that means people from many specialties as being part of your high-level care. So your head and neck surgeons, your radiologist oncologists, your medical oncologists, palliative care, to name a few. We are appropriate at any stage of disease, so at the time of diagnosis is always a good place to start. And with hospice level of care, it's really when people have what's end-stage disease. So if a disease was to allow it to run its natural course, that it would be a life-limiting condition. And the big standout again, palliative care, concurrent with curative treatment, hopefully, and then hospice when we allow the body to go through its natural course. Just to highlight what an interdisciplinary team is, so this is a structure for palliative medicine that you'll see with really any institution that offers it. Again, the concept of high-level patient-centered care, starting with the person and the people that they come with that we take care of. It comes with clinicians, so your physicians, your nurse practitioners, your physician assistants. It comes with a really robust supportive staff. We have great nurses. It also comes with nutritionists, physical therapists, occupational therapists that work with you to meet what your care goal needs are. That may be different. It may be towards recovery or maybe energy conservation. And we also work closely with people who have a lot of experience and expertise with psychosocial support. That includes our social workers, our psychologists, and even chaplains who can also acknowledge and incorporate the spiritual side of care that is so important. So to talk briefly about pain during cancer treatment, there are 3 types of pain that we see our patients often face as they go through head and neck cancer care. That can be cancer-related pain, and just to highlight the resources so that patients know that they do not have to go through this alone, palliative medicine is always a great place to start if you need a patient who has really high cancer pain and is unable to find relief. Again, starting with your oncologist, even your primary care, pain management specialists, and in some cases, patients maybe need to have an additional support of an addiction medicine team. For treatment-related pain, that could be chemotherapy-related or even radiation-related. And of course, you can come to us in palliative medicine to help with those symptoms, even preventatively. Your oncologist, primary care, pain management, addiction medicine, and radiation oncology. And I always like to highlight that pain is total. So it's never just the physical symptom, it's your overall well-being. If we're not able to take care of you as a person, it's hard to take care of your physical symptoms too. And within our interdisciplinary team, as we had just talked about, we really address this as part of our normal evaluation, looking through barriers, even working with our social workers in the simplest sense of even financial distress, appointment burdens, working with psychiatry if needed, and also our psychologists. And just to highlight, there are some patients who may develop chronic pain syndromes after treatment. Just when you're seeking and starting your cancer-related care, there's a lot of emphasis on getting straight to treatment, starting your plan with a very clear treatment plan. But what happens after when things are better and you're still feeling unwell? So in palliative medicine, we do a lot of warm handoffs, meaning that we start talking about ways to get you feeling better, making some adjustments so that you can have a sustainable quality of life after you're treated, working closely with your primary care doctors and potentially pain management and addiction medicine too. So this is our resources. I think, Lara, I should probably turn this back to you.
All right, thank you to all of our panelists. That was excellent. All right, so we are actually going to move on to the question and answer session. Okay, this will take place here in person as well as remotely. There's going to be 2 moderators that are going to be circling the room. Okay, so if you would like to ask a question, please raise your hand so they can identify you, and then they'll be able to bring the microphone over for you to ask the question, or you can tell them the question, they can ask it for you. And those individuals that are remotely accessing today's symposium, you can type your question into the Q&A section of the Zoom, and then we'll be able to identify that and hopefully be able to answer those questions as well.
Hi, I have a question. I'm a year out, actually today, from radiation. Thank you. My question is, the last couple of months, well, yeah, almost a couple of months now, I'm having pain in my upper arm into my shoulders where like the range of motion's gone. If I slightly even try to reach for something, it causes excruciating pain. Has anyone else experienced that? What are you doing for it? What can I do for it?
Sure, so this might be Jamie.
I think, is this on? Okay. We see that very often after radiation. It's typically damaged to a nerve. Although we didn't, completely sever it or anything like that with surgery, you can still have nerve dysfunction after radiation. So that's probably why you're getting like a radiating pain and that sort of stuff. It can be both sides. If it is both sides consistently, we usually do want that to get some type of imaging if it is going down into both of your arms. So you could ask your doctor for something like an MRI. But we would work a lot. I mean, we're going to do a full musculoskeletal like exam on you, and we're going to feel, why is this happening, and what can we do? What can we do to optimize your muscles to help lessen the symptoms? We can't like go abracadabra and put our hands on you and heal your nerve, but we can certainly work with you through exercise, hands-on work, and stretching, that sort of stuff to get you in a more optimal position until hopefully that nerve does heal. Thank you. You're welcome.
Thank you so much for all of your information. I'm wondering if you could do a demo of some of the maybe 2 or 3 most effective stretches you've seen, what's most commonly helpful. We could use some more practical strategies from y'all. Thank you.
Yeah, of course. So mostly our patients want to be forward after everything. And that is because, a lot of stuff is tightened if you do have a neck dissection, but also just you guys are in pain, especially during radiation. So what happens is your pec muscles get really tight. So I typically tell people the best way to stretch them is in a door, like a 90-degree angle. And you want to make sure you keep your shoulder down, and you want to just lean in until you feel a big stretch across your chest. Another muscle that gets really tight is our sternocleidomastoid and our scalenes. So those are right about here. So we want to take our neck and lean it back and over as best as we can. I tell people for a little added stretch, you can kind of take up the slack in your skin if you have any. It's not fibrotic. And you can kind of lean that way as well. Those are the 2 biggest ones I have. The other thing that I really have people do, and I know speech therapy teaches this a lot too, is really try to just practice tucking your chin, almost like you're just nodding the very top of your head, so your skull on your spine. And you can do this in the car even, and try to press the back of your head into the headrest. And that's going to kind of stretch everything on the upper back of your neck and help strengthen the front muscles. So those are just 3 that I give pretty much everybody. So.
Do we have any online questions?
Oh, yes. Are there I cannot see them.
Okay, I have one more.
Sure, I have 2 quick questions. Thank you all again so much for presenting this great information. I'm a young survivor of head and neck cancer, so in a pretty rare category myself, and that's related to my first question of experiencing symptoms that don't seem to have an answer, and I won't get into all of that, but what when we face just unknown, like uncertainty in what we're experiencing, what do you all recommend doing if we're not finding answers to things?
Wow, that's a great question, and a tough one to answer, so thanks a lot. No, I'm just kidding. So, no, it's a very important question. And this is a discussion I have with a lot of patients. There are certain things that will kind of get better on their own. There's other things that will get better with practice. And there are other things that might not get better, or maybe they'll get a little bit better. Again, it is a long process to recover from the treatment. So I think it is important to understand that just how you are today is not necessarily how things will be in the long term. Definitely, and you might already be doing this, but try to get connected with certain professionals who can sort of have this discussion with you on an ongoing basis to sort of separate okay, this is something we can work on, and this is something that, there's not much we can do. I think a classic example, I have a lot of patients who, they have dry mouth, and it's a chronic problem. And what do I do with this? How do I fix it? I don't have any exercises for you that can help with that, right? There are these sort of short-term measures you can take to improve the saliva production in your mouth, but they kind of come and go, and then you're left with the same problem. So that's an example of something that, we can manage that, but to my knowledge, there isn't a great way to fix it permanently. So it's really a combination of keeping yourself educated, talking to people, having these discussions, and focusing on what you can fix and what you can't fix, sort of learning to adapt.
I would also add, definitely turn to all of your medical team with questions, symptoms you have, but also speak to other patients who have the same cancer as you and as close to your age group as possible, because it is fundamentally immeasurable when you can reach out to a group of people and say, hey, I'm literally on a WhatsApp or a text, no doctor appointment, no waiting. Hey, this is happening to me. Hey, what's this? Hey, I went to dinner and I feel this. Hey, I'm sending you a picture. Have you ever had this? I think having people who are dealing with the same thing you are, who are open to communication, is really important, because yes, always rely on your medical team, but sometimes, at 1 o'clock in the morning when your mouth hurts and something doesn't look right and you can't get a hold of a doctor, you can sometimes get a hold of some of your fellow cancer patients, and they will help alleviate some of the anxiety that you might be having while you wait to see a medical professional.
I think I just want to add as well that facing uncertainty is something that a lot of our patients experience when they're having a new serious diagnosis that they're working through, even if it's head and neck cancer. And that's something that in palliative medicine and also everybody who is part of your care team really worries about. We recognize that these are challenges that we may not possibly relate to or imagine, but we appreciate open communication, and that's something you can disclose always with your care team. I think just remember too, as symptoms come up, you understand your body the best. So as you're recognizing these things, feel that you can write them down and have them ready to review at your follow-up appointments with any of your clinicians or anybody on your care team, because we're all here to make sure that you're taken care of and getting the best quality care.
We're going to go to some of the online questions real fast. The first one, is it better to sleep sitting in a recliner?
No, please don't sleep in a recliner. It's going to hurt your neck and your back. We really don't want you sleeping completely flat for lymphatic drainage. Reasons, I'm assuming maybe this person online, if you don't have swelling, you are allowed to lay flat. But if you do have swelling, we want you slightly elevated, but in a bed. So you can either prop up on a few pillows or on a wedge pillow, which you can purchase online very easily.
Perfect. And the next one is, when is the best time to start patients with speech and physical therapy? Do you see benefits to starting it prior to radiation, as maybe there is more pre and post assessment?
Absolutely, before, early and often. Preventative rehabilitation is really the best approach for people who are going to get radiation. You want to do everything you can before and during treatment to maintain function. It's a lot easier to keep function than it is to regain it. It doesn't mean you can't regain it, but you definitely want to get as ahead of the curve as possible, at least in terms of swallow function when you're getting radiation.
Okay, and the last one is, are there any exercises that can help with the numbness in feet due to chemotherapy and radiation?
There are. There is a lot of mixed research on chemo-induced peripheral neuropathy. To show you exercises right now would be a lot, so I would suggest that you do go seek an evaluation by a local physical therapist. But we do work a lot on balancing, desensitization, taping can help a lot too. But there's not much that I can show you like really quickly right now. So yeah, I would recommend that you go see a physical therapist, and they can definitely help you out with that.
Okay, are there any more? Oh, perfect.
My name is Tammy Robinson, and I'm 5 years, clean, as you say, but I'm having problems at eating. They put me on marijuana, but it's still not having me to eat. I'm having real problems at eating, and then I'm losing my teeth.
I'm sorry to hear that. So there's probably multiple factors and multiple panelists that will comment on this. Do you want to start off with Ian, and then we can move to Angela?
Sure. So first of all, congratulations on being 5 years post-treatment. That's
Thank
pretty
you.
remarkable. It takes a lot to get to that point. So I guess my first question is, do you have an appetite? Do you want to eat?
I've been drinking a lot of booze.
Okay.
They tell me I need to drink water because I'm dehydrated a lot.
Okay.
There's a lot of stuff going on
Yeah.
right now.
Yeah. Well, that difficulty eating and difficulty with appetite, it's complex. There are a lot of reasons why someone's appetite might be poor, or why you might have trouble mechanically consuming whatever you do try to eat. So it's tough to sort of give general advice, without knowing your specific case.
I had neck cancer.
Right. Beautiful. But no, I think sort of coming back to some things we've already talked about, it's important to, and so I'm a speech therapist. I work in the field, so I'm going to be sort of biased, but it's important to stay connected with a speech therapist. And that's something that we can talk about later.
And I have, they said I had some of my vocal cords.
Mm-hmm.
So I'm going through a whole lot right now.
It sounds like it. It sounds like it. And I think it sounds like there are some things that you can work on to try to get better. And just, again, sort of bringing it full circle. It's a long road to recover. It takes a lot of effort and a lot of help from different people. So I would encourage you to meet with a speech therapist and talk about it some more and see what they can do to help. And I'm happy to talk to you today.
Thank you.
I think we have time for one more question, but please, there's index cards moving around. Write your questions down. Every question that isn't addressed during the session so we can stay on time will be addressed at a later date in a follow-up. Okay, so this is our last question.
Lucky me, thank you. When I was going through diagnosis and making decisions about treatment options, I was really helped a lot by having data and information about probability of cure, likelihood of recurrence. That information was there for me. Now that I've gone through that and I finished treatment at the beginning of 2023, I'm interested in the same information on long-term side effects. And having some of the statistics put together. Ian, you shared something I hadn't seen yet with the 45% statistic, and what was it, 4 to 8 times more likely than the rest of the humans walking on the planet to have dysphagia. That's helpful. Do we have that resource available? Can somebody point me to it for other types, not just speech and swallowing, but what is it, carotid stenosis and dental? I'll ask the other panels too, probably, but does anybody know that kind of information is available so that we can understand our probability of long-term side effects? Having swallowing problems 5 years out scares me, and a lot of others. And also, along the back the second layer of that would be, okay, if we have that information, do we also have information about the likelihood of preventing problems? Hearing Susan talking about going to physical therapy twice a month, I think you said still. I wrote that down. Do I need to do that? Should I be doing that preventively? And what would be my upside statistically if the information's available? I'm asking for a lot, but you know, everybody does their, every time you go to an appointment, you fill out a survey about how you're doing. Is that, does somebody need to pull that together, or is it already together? Thank you.
I think it's really hard to, I'll speak from experience because I'm a researcher by nature. I like to know all the facts always before I make decisions. I think I've personally found it very hard to find consistent statistics across the board. And I think it's, you know, because there isn't as much funding towards research. A lot of the research that does exist is of a certain age group of people with certain stages, with certain risk factors or hereditary or genetic notes. And so if you don't fall into that bucket, which I don't, it's hard to land on like really hardcore confirmed statistics. And the research keeps changing and evolving as more and more is done. Certainly, I'll defer to all of the medical experts there, but I think it, for me, is less about the number of the statistic and focusing on the number and more about like the overall thematic. So yes, research shows if you continue to go to physical therapy and continue to fight against the fibrosis, which is cumulative over time, it builds and builds. So if you continue to fight against it, you will generally, right, have a better outcome. But getting to a number is really hard.
I think that question is a really great one because it's so easy to look online and just find your own research, as Susan said. I think one way you can always go about it, because I think what you're coming from is you just want to be informed and you just want to be educated in just what your future might look like. So there's survivorship clinics that are usually associated with cancer centers. You can always start there. I think in some cases, even your primary care doctor may be a first place to start. But I think whenever you have a list of questions and maybe a very specific one that, you know, is just so nuanced to you, you can always feel comfortable reaching out to either your medical oncologist or even palliative care, someone, whoever, to start and just say, these are my questions. You know, these are the things I like to know about. I don't want to put anybody on the spot at my appointment. Is this something you can help me understand in a follow-up visit later and we can maybe go over? And that may be more helpful because I think everybody's cancer care is a little different. You know, I think what we know are things that we counsel about but may not necessarily happen to you, right? So I think those are always a little bit harder to answer, but doesn't mean you can't come from a place of just wanting to know more.
All right, and we'd like to thank our panelists for being here. Thank you so much for all your expertise.